Okay, so let's do the lecture on drugs for dysrhythmias. This is chapter 30 in your Pharmacology for Nurses textbook. Okay, so the cardiac conduction system, okay, we talked about how the main purpose is to really regulate the heartbeat and to maintain cardiac output. So dysrhythmias. So it's an abnormality of the electrical conduction or the rhythm in the heart. They're also known as arrhythmias. So in the hospital setting or in the clinic setting, you'll hear dysrhythmia or arrhythmias, same. They really do range from harmless. There's some people who may not even know that they have a dysrhythmia, but then it can lead to life-threatening because there are lethal rhythms. So again, like we talked about in class, how do we know someone has a dysrhythmia? Maybe they're complaining of chest pain, fatigue, shortness of breath. Maybe they have heart failure and then they're having edema and then they have a dysrhythmia. Now, symptoms can range from they don't have any to sudden death. They have severe chest pain and then they go into cardiac arrest. Now, when they go into a cardiac arrest, we all know the first thing we should do is check the pulse, okay? And then we give compressions. There's multiple medications we can give if someone goes into cardiac arrest, and it's due to those dysrhythmias. So dysrhythmias, okay, they are quite common, especially atrial fibrillation is very common. They do increase our patient's risk for stroke and heart failure because if you think about the heart has different pumps, right? Left. Now, if one side is failing because of the electrical conduction and it's just not firing correctly, one side's working more, so on and so forth. So there's tons of classifications of dysrhythmias. I showed you these EKG strips. You do not need to know what these EKG strips mean, but I wanted to give you an idea on what it looks like normally and then what everything else looks like because they're not good. Dysrhythmias, it's not a regular beat. It's not a regular electrical conduction. Now, depending on the location of the dysrhythmia, okay, it could be atrial or ventricular. Also the different types. So there's flutter, there's fibrillation, and there's block. So it could be a complete heart block, second degree, third degree, first degree, or it could be atrial flutter or ventricular flutter. Atrial flutter is most common type of flutter. And then there's fibrillation. So you'll hear VFib, so ventricular fibrillation, or you'll hear atrial fibrillation. So the most common one for fibrillation is atrial fibrillation. It's the most common. Now the different types of dysrhythmias. The first one I'll show you is going to be atrial or ventricular tachycardia. So you'll see on the left-hand side, that is an atrial tachycardia. I just want you to look at it and see the difference of it. It's going very fast where this is sinus rhythm, which is our normal sinus. The next one is going to be our ventricular tachycardia. Then we have our, this is ventricular flutter. Then we have our atrial flutter here. Okay. Then we have atrial fibrillation, which is, again, like we talked about, this is the most common fibrillation. Okay. And then we have our atrial flutter down here. You can see how atrial flutter is like a sawtooth. And then fibrillation is like, it's like they're vibrating. Then we have heart blocks, which I don't have a picture of. There's different types of heart blocks, and that's why I didn't bring it up. Then we have the premature atrial ventricular contractions. So they're known as PVCs. So it is just, you'll hear they have an extra beat. This is this right here. Then we have sinus brady. So this is when their heart rate is less than that 60 beats per minute. And you can see the QRS, the T, and the P are very spread apart. But I just wanted to show you the different types of EKG strips, just to have an understanding on if you do see this, this is what they mean, especially in your clinical setting. Now, the flow of the electrical impulse through the normal heart, okay, we know the dysrhythmias, they're a defect. There's something going on with that conduction across the myocardium. There's action potential, so that's a signal the cardiac muscle cells to contract, okay? They beat in that synchronous manner, okay? Then the SA node, we all know this is our pacemaker. And it helps us to be in sinus rhythm. We want to be in sinus rhythm. So people can have dysrhythmias either with healthy or even diseased hearts, especially if they have heart disease or heart failure. It can decrease the cardiac output for our patients. And then we definitely, like I talked about for those diseased hearts, we want to make sure we're looking at our patients who have heart disease, if they've had a myocardial infarction. Now the EKG, like we discussed, it really measures the wave of electrical activity across the myocardium. It changes to wave patterns, so then you can see the PQRS, and then you can determine actual pathologies. Here's a question for you. Do you remember back in the very beginning in semester 5 and 6 when you talked about hyperkalemia? Where on the EKG would that be affected? Peaked T waves. Okay, if someone comes in and you see peak T waves on their EKG, my first thought is, high K. What's your next thought? Why would someone have a high K? Maybe they have a high K because they're dialysis and they missed a couple sessions. That's a possibility. Maybe they have renal disease. Absolutely, they're not able to excrete. There's multiple things to think about when you do see the EKG. We can also see a myocardial infarction on an EKG. Then they'll have to get sent to the cath lab, okay? And they will have to get a stent placed in their coronary artery to open up that blockage. You can get a lot of data from just looking at someone's EKG. Now, here's the relationship. So the P wave, so the atria depolarize and contract. So the atria contracts, and then that QRS is when the ventricles start to depolarize and contract. Now, during that PR, okay, we have the PQR, okay? This is the time that starts with that atria to depolarize, and then at the very beginning of the QRS complex. Now, again, like the QRS complex, that's when the ventricles depolarize and they contract. And then the T wave is when the ventricles repolarize and relax, and now the atria is filling up with blood. And then the P wave starts over. Now imagine if this synchronous relationship with the electrical conduction was not functioning correctly. Let's say the atria was contracting, but the ventricles weren't pushing out enough. Okay, and then let's say it's a patient who has heart failure. Now, if we know someone is possibly having heart failure, what lab, okay, would you like to look at? It is known as the BNP, brain natriuretic peptide. This is going to let the providers and the nurses know how much fluid they have. Also, what percentage do we want to look at if someone has heart failure? The ejection fraction, right? We want to look at the ejection fraction. Now, if someone has heart failure, what does their EF, their ejection fraction, fall below? It's going to be 45%, right? Okay, so the next is some non-pharmacological therapies for dysrhythmia. So if someone's in a dysrhythmia, depending on their dysrhythmia, they can have a cardioversion, which you're going to have the co-cart. You'll turn on the co-cart and you'll actually put it to synchronize for cardioversion because it's going to line up with the QRS. Now you could do defibrillation. So they could defib a patient. They're going to, they will hopefully sedate our patients if we can, but sometimes we have patients who we just can't sedate in time because it's life-threatening. Now, those are for our serious types of dysrhythmias. We're going to use cardioversion and defibrillation. We talked in class how they really are increasing using these non-pharmacological therapies instead of pharmacological due to the reoccurrence of new or worsening dysrhythmias when they use drugs. Now, with with cardioversion and defibrillation, there's an electrical shock that stops all the electrical impulse in the heart and allows that SA node to gain control again. Now, you'll hear that they restart the heart. That's what they're doing here. Now there's catheter ablation. So it's a procedure that scars tissues and that attacks the scar tissues in your heart to block the abnormal electrical signals. It's really used to help restore a normal heart rhythm. We have our cardiac pacemaker. Okay, so it really helps pace the heart at a set rate. Then we have an ICD, the implantable cardioverter defibrillator. So it's a combo of a pacemaker and a defibrillator. And these will be placed on your patient's chest right up here. Now, action potential. So it's the electrical impulses across the myocardium. Okay, it's found in our neural and our cardiac cells. Now, there's exchanges in the extra and intracellular ion polarization. Okay, and then whenever the cell membrane with a negative membrane potential equals polarized. Okay, so then there's that negative membrane potential. We have sodium and calcium outside the cell, and then you have potassium inside the cell. So the generation of action potential, we have when the sodium ion channels open, the sodium ions rush in, causing the depolarization, that contraction. Now, when the calcium ion channels are open, that's when the calcium ions enter the cell, stimulating that cardiac muscle contraction. The SA and the AV cells are going to depolarize in the response to this calcium ion influx. Now, repolarization, if you think of repolarization as relax, it's returning to that polarized state. So the sodium pump is going to remove the sodium, and the potassium ion channels are allowing that potassium back to move into the cell. Now, the pharmacological strategies to really help with the dysrhythmias, they are moving away from this because it can cause a worsen or new dysrhythmias, but we have multiple drugs. So there's a lot of potassium, sodium, and calcium channel blockers. They really do prolong the refractory period. Okay, there's that brief period in the conduction cycle when those myocardial cells cannot produce another action potential. Now, our antidisrhythmic drugs, okay, the mechanism of action is, again, blocking the flow through those ion channels, that conduction. We're trying to block. So if it's a potassium channel blocker, it's blocking potassium. Now, if you think of that, if you have a potassium channel blocker, what do you need to check prior to giving this drug? Potassium. What drug do you want to check before giving potassium? Which antidiuretic or antidisrhythmic? Amio, right? Okay, so then it's, again, we talked about how it could worsen or create new dysrhythmias, and they're getting away from antidisrhythmic because of the non-pharmacological therapy is improving. Now, our first one is our sodium channel blocker. This is the procainamide. So this is used to block the sodium ion channels, which is now helping slow the rate of the impulse conduction across the heart. Okay, so it helps with atrial and it helps with ventricular dysrhythmias. So there are some adverse effects. Now, we talked about how almost, you will read this in your drug guide and every guide, everything's nausea, vomiting, diarrhea, right? Now, think of something that is bigger. What is an adverse effect? Nausea, vomiting. Is that an adverse effect? Okay. Is that going to hurt them? No, not always, unless in the scenarios as it's an older adult that we have electrolyte issues, we're worried about an imbalance. But think about what the mechanism of action was. Okay, slowing down the conduction. So I'm worried about bradycardia. Okay, there is a lupus effect, and in high doses it can produce CNS effects. Now, it blocks the sodium ion channels in the myocardial cells, reducing that automaticity and slowing the conduction of the action potential across the membrane. The most common form to give this is an extended release tablet, but you can give it IV and IM form. You can. So with this sodium channel blocker, okay, again, knowing that it's slowing the conduction of the action potential, It's slowing down the heart, right? If that dysrhythmia is going really, really fast, okay, I need to slow it down. So would I give it to someone who has severe bradycardia? No, it's contraindicated. Don't do it. You are also going to watch for hypotension. You want to watch for hypotension when giving this drug. Now, it's a pregnancy category C, so here in our adverse effects, it says hypotension, and then again, it can cause some confusion and psychosis, but also think of bradycardia as well. Black box warning, okay, so it has that lupus-like syndrome. So it only says here 30 to 50% of patients who are taking it for more than a year. Now, yes, that's important, but it's 30 to 50% of patients who take it for more than a year. It's not common for these patients to take it for more than a year, depending on what type of dysrhythmia that they have. So again, like most common of our dysrhythmic drugs is going to be the overdose of supportive care. If I'm worried about bradycardia, especially severe bradycardia, or if I'm worried about hypertension, you're going to give vasopressors and you can possibly give atropine as well. Now we have our beta-adrenergic blockers. Propranolol, we have an LOL. It's a beta blocker. So we know that it's going to decrease the heart rate, okay? Now, with propranolol, one of the adverse effects is hypoglycemia. With hypoglycemia, if I'm worried about this, I'm thinking about really what type of patients am I going to be dealing with? What type of patients do we have a lot right now? Diabetics. Obesity is there's a high rate of obesity, and especially with type 2 diabetics, and they're taking insulin. Now, if they're taking insulin, it's going to lower their blood sugar, but then also the sugar could be low if they're on propranolol, and because it's an adverse effect. So people may think it's the insulin, but really it's the propranolol which is causing the hypoglycemia. Now, propranolol reduces the heart rate, it slows the myocardial conduction velocity, and it lowers the blood pressure. So what do you need to do prior to giving this medication? You need to check the blood pressure and check the heart rate. If the heart rate's less than 60, you should be doing an apical pulse and do a pulse deficit. Check the radial and check the apical. Listen to the apical, feel the radial. Two people compare should be no more than 2 points away from each other. Now, if there's a big pulse deficit, you need to report that to your provider. And if they're lower than 60, you need to report that to the provider as well. Now, your patient should not have an abrupt discontinuation because it could cause a myocardial infarction, it could cause a serious, severe hypertension, and it could cause ventricular dysrhythmias. They should tamper this off. They should not abruptly stop it. Again, if the pulse is less than 60 beats per minute, you need to notify your provider. So again, common adverse effects, this includes fatigue, hypertension, bradycardia. Because it does slow down the heart rate, patients who have cardiac disorders such as heart failure, they really should be monitored. Now we talked about the gradual decrease of this medication. It should be reduced over 1 to 2 weeks to make sure that they don't get severe hypertension, an MI, or any ventricular dysrhythmias. So with the overdose, you're going to want to look at the treatment, okay? It's again, think about it. It's propranolol, it's a beta blocker. It's going to lower the blood pressure, lower the heart rate. So if it's lowering my blood pressure, lowering my heart rate, I'm going to want to be aggressive with my vasopressors, probably give them lots of fluids, give them atropine. Now, again, with the hypoglycemia with propranolol, I might want to give intravenous glucagon because it's going to help reverse that cardiac depression and then hopefully increase the myocardial contractility, increase the blood sugar, increase the heart rate, and improve the AV node conduction. Now, amiodarone. This is our potassium channel blocker. So this blocks the potassium ion channels in the myocardial cells, which prolongs the refractory period of the heart. Now, it's used persistently for those resistant ventricular tachycardia. So if someone's been in VTAC and they've done the non-pharmacological interventions, we'll give them amio. Usually it's a bolus and then it's a drip. So if they're in this ventricular tachycardia or even atrial, and it's they're not getting out of it, we'll give them amio. It can be used for AFib. It has been used for AFib, but it's commonly used to treat those resistant ventricular tachycardia. Now, some adverse effects. It can cause new dysrhythmias or even worsen existing ones as well. Now, it has a very extended half-life. It can exceed over 50 days to be in the system. Also, it can last 4 to 8 weeks after the drug has been discontinued. So we need to constantly monitor those patients. Now, before you give this, you really need to monitor their labs, especially their potassium and their magnesium levels. Those should be corrected prior to initiating your therapy. So make sure you review over your labs to make sure you have a good idea on what your ranges are, especially the mag and calcium, because those always get confused. Calcium, 8.5 to 10, okay? And then your mag, 1.3 to 2.1. Now you'll see different ranges, but as long as you're within those, they're not going to be far off. It could be 1.5 to 2.2 for mag in one book, 1.3 to 2.1 in another book. Don't worry, I wouldn't worry about it, but at least you know which ranges there are. You should know your ranges. So again, amio will cause an ammonia-like syndrome in the lungs. Okay. The pulmonary toxicity can be pretty fatal, and then you need to have a baseline and do a periodic assessment of the lung function. So, contraindications, it is contraindicated with patients with severe bradycardia, okay, cardiogenic shock, which we'll talk a little bit more about shock next week. And then drug to drug. So if someone is taking amio and they're taking DIG, amio can actually increase the serum DIG levels up to 70%. It's a lot. It can also block the metabolism of warfarin, requiring lower doses of the anticoagulant. And then again, the treatment of amio overdose is really targeting the reversing the hypotension with vasopressors and atropine for bradycardia. And then we have our calcium channel blockers, our verapamela. So that's blocking those calcium ion channels, which reduces the automaticity and slows the myocardial, the AV conduction. So this is to treat those supraventricular dysrhythmias and angina. We can give this for angina. Now, what is angina? Chest pain. It is chest pain. Some adverse effects with this, because it is a calcium channel blocker, it's slowing the myocardial conduction, bradycardia, hypertension, and they can get a headache. Now, another, for the mechanism of action to help with the angina, it helps dilate those coronary arteries, and it's used to treat angina and for hypertension. So when you're talking to your patients, they should swallow the capsule whole. They shouldn't chew it. They shouldn't open it. It's going to be a capsule. Some adverse effects like we discussed, hypertension, bradycardia, it could be flushed skin, and then contraindications. So patients who have severe hypertension, severe bradycardia, they should not be doing this. Also, patients who have any renal or hepatic impairment as well. Now, verapamela. So far, this is the one medication we've talked about with food. So, grapefruit juice, it can increase their levels. So, think toxicity. Now, again, with overdose, again, hypertension, vasopressors, bradycardia, atropine, so on and so forth. We have adenosine. We talked shortly about adenosine. I'm going to go over it because you will see this if you work into the emergency department. Adenosine is really to help decrease the SA node and slow the conduction through the AV node, but it's not acting on blocking on any ion channels. Now, this is for those serious atrial tachycardias, such as for supraventricular tachycardia. When you're giving adenosine, your patients can have a flushing of skin, they can feel short of breath. Now, if you're giving DIG, you probably talked about this with your previous professor, but some common adverse effects when someone is having too much DIG is nausea, vomiting, headache, visual disturbances. Now, when you're giving these antidiuretic medications, or not, I keep saying antidiuretic, but antidisrhythmic medications, you really need to monitor your patient. Closely monitor their cardiac function. Think cardiac, respiratory, neuro, and you need to monitor those vital signs. Monitor this for the hypertension. Monitor for their level of consciousness. Teach your patient to take the medications as directed. And then if any patients who have heart failure or any renal impairment, if they're taking sodium channel blockers, it's contraindicated. Now, if they're giving a beta blocker, a betaadrenergic blocker, it's going to be contraindicated with patients who have a heart block, severe bradycardia, or an AV blocker or asthma. You're going to want to monitor for the hypertension and hypoglycemia. Now, which is your drug for beta, for the beta-adrenergic blockers? Verapamela, right? Again, with the hypoglycemia, if your patient is, I think of diabetics. If I see hypoglycemia, I think of, well, who would I be worried about with hypoglycemia? It's my diabetics. If they're taking insulin, a lot of people might think that it's the insulin that's causing the hypoglycemia, but really it's an adverse effect from the propranolol. Now, you also want to teach your patients how to measure their heart rate correctly. They need to monitor it for a full minute, okay? Check their pulse. If it's less than 60, they notify their provider. If they are feeling dizzy or anything, they need to notify their provider. Rise slowly, okay? Remember orthostatic. They need to change positions really slowly, and then report any signs of heart failure. So you all know what signs are heart failure of. Edema, shortness of breath, coughing, the abdomen, okay, if they're getting any swelling, so on and so forth. If they're gaining weight, how many pounds in a week? 3 or more in a week, okay? Teach the patients not to discontinue the drugs abruptly. Now, for potassium channel blockers, they really need to be used cautiously with patients who have any heart blocks. They should not be used during pregnancy or lactation. Avoid sun exposure and take with food. They can take it with food. Our calcium channel blockers, don't take it with patients who have any heart blocks, severe hypertension. You're going to want to monitor those hypertension, and especially with the elderly. They should report any palpitations, any blood pressure changes, edema, or any shortness of breath. Now, for the miscellaneous drugs, okay, we talked about DIG toxicity, visual disturbances, nausea, vomiting. Also, any other complaints, such as like they need to monitor their heart rate, blood pressure. If those are off, they need to inform their provider. So, drug therapy. Before you give any dysrhythmic medication, you need to get an assessment of their cardiac output. Okay, you need to get a baseline of their EKG because you need a baseline of all this prior, during, and after. Some nursing diagnosis: decreased cardiac output, risk for decreased cardiac tissue perfusion, knowledge deficient, especially with their medications, and risk for injury. So planning, improve their cardiac output, understanding the drug therapy, how to take the medication, why are they taking the medication, how long do they take the medication. When someone has hypertension and they start taking metoprolol, right? It's a beta blocker. And let's say their blood pressure is controlled now. Do they still have hypertension? Yes, they do. You will come in contact with a lot of patients who I'll ask in the ED, I'll say, what type of medications are you, or what type of medical problems do you have? I don't have any problems. Okay, do you take any medications? Oh yeah, I take metoprolol, I take atorvastatin. Oh, so you have hypertension? No, I don't have hypertension. Yes, they do. They have hypertension. It is controlled hypertension, but they have hypertension still. So, implementation, get a cardiac rate, the rhythm, get an IV. You have to get a patent IV. Investigate why are they having dysrhythmia. Dysrhythmia, it could be for an electrolyte imbalance. Okay. Evaluation. So evaluate, did you have a positive outcome? Or after you gave the medication, did they have a worsening or new dysrhythmia? Now, I'm going to let you guys go through this. This is the nursing practice application. It goes through each one again. I'm just going to start clicking through so then you can pause the video and you can read it on your own time. Okay, that is the end of this video. If you have any questions, please reach out to me and I will see you next week.